Right, good morning everybody. So my name's Grant Stewart. I'm a urologist in Cambridge in the United Kingdom. Axel Becks and I are delighted to chair this exciting session around one of the next frontiers in the management of kidney cancer, we hope, so controversial topics in the perioperative space. So we've made huge advances in the treatment of metastatic kidney cancer, and with the availability of adjuvant treatment that is now moving into localized disease in terms of the use of systemic therapies. But we really now need to better understand the potential for neoadjuvant treatments in kidney cancer, because we're lagging behind other tumor types in that regard, where there have been treatment individualization and real improved outcomes, and actually the rationalization, the reduction in use of adjuvant treatment. But there are a lot of questions to answer to get us to the point of practice-changing trials in this space, many of which we're going to discuss in the session, and we look forward to hearing your questions at the end of the session. You'll see that there's a lot of momentum that's been gathering over recent months around how we best tackle this subject, and we'll touch on some of that. So I think we're going to start with Zaid Tipu. So Zaid has recently defended his PhD, which he undertook with Samra Turalgic at the Crick, and is now working as a clinical fellow at the Royal Marsden in London. And Zaid's going to talk to us, introducing this topic about why might neoadjuvant therapy be beneficial in kidney cancer. Thanks, Zaid.
Thank you very much, Grant, and thank you to the organising committee for extending the invite for me to speak this year. So I've been tasked in the next 5 minutes or so to outline the rationale of neoadjuvant treatment and why it might be beneficial in kidney cancer. And to really try and answer this question, I'm trying to transpose some of the translational and biological insights that we're starting to build and develop from the advanced setting in those patients who are having deferred cytoreductive nephrectomies to see how this can underpin potentially improved efficacy in a perioperative paradigm. So this is an audience that will be very familiar with the fact that adjuvant pembrolizumab is now a standard of care for those with intermediate to high-risk localized clear cell renal cell carcinoma. This is off the back of a DFS and now OS benefit from the KEYNOTE-564 study. There are, however, challenges here, and there are difficulties in managing nuances of decision-making where we are relying on clinico and pathological risk stratification tools alone. We know that adjuvant treatment represents an over-treatment for a proportion of patients, and yet the margins for benefit are relatively narrow. What complicates decision-making here is a lack of implementable biomarkers, and this isn't despite a lack of significant effort in this space. But historically, we've relied on archival tissue baseline pre-treatment samples without being able to characterize dynamic changes under the selective pressure of therapy, which may better reconcile response and resistance. So we know that broad-scale molecular profiling efforts have characterized the genomic landscape of clear cell RCC, and this has prognostic value in this space. So the addition of 2 or more driver gene mutations above and beyond VHL associates with the recurrence-free survival in patients now eligible for adjuvant therapy, and increasingly well establishes the role of copy number alterations, chromosomal complexity, and particularly the loss of the short arm of chromosome 9, associating with metastatic competence. The challenge with genomic biomarkers is that they inconsistently associate with prediction to therapy outcomes, associating with both response and resistance to immune checkpoint inhibition in the context of advanced disease. We know now that there's been an increasing focus on characterizing the tumor immune microenvironment, the TME, the interaction of tumor with a number of different immune cell subsets. And beyond simply looking at T-cell infiltration or quantifying that, we understand that the phenotype of these subsets become important, as well as their interaction beyond T cells. So most notably, the consistent and emerging evidence of mature tertiary lymphoid structures, these ectopic lymphoid organs which often present at the tumor margins as important sites for B-cell maturation and differentiation into plasma cells, which then propagate into the tumor bed and exert anti-tumor immunity. But again, our insights here are largely limited to baseline tumor tissue, so understanding the effects and selective pressure under therapy to result in dynamic changes within the TME are relatively limited. And I think we understand the value of dynamic biomarkers from the establishing and emerging role of circulating profiling. So beyond traditional ctDNA-based assays, the emerging role of peripheral immune phenotyping to characterize multiple immune cell subsets which associate with response and resistance. And rather than just looking at a static baseline time point, the value here is looking at delta changes from baseline treatment to early on treatment samples, which better reconcile these differential outcomes. And then beyond PBMC profiling, as is well known in this room, the emerging and now established role of KIM-1, not only prognostically, but relative to its predictive value, both in the adjuvant and in the advanced setting. So these neoadjuvant studies and paradigms present this window of opportunity to characterize dynamic changes intratumorally and peripherally under therapy, which may be able to redefine and validate the biomarker signatures that we are developing. We know that a robust framework for pathological response in the context of neoadjuvant disease is still pending, but this may provide a framework to understand the rationale for adaptive therapy strategies, de-escalation of therapies in the context of what is defined as excellent or major pathological response, or PathCR, or potentially consideration of changes in cross-modality treatments should we robustly be able to define what non-response is. And again, so much of our limitations in the biomarker discovery space, particularly tumor-related, is this pervasive concept of heterogeneity, so diversity spatially. And where we can access the entirety of the nephrectomy specimen, this overcomes some of these challenges in the context of neoadjuvant treatment studies and paradigms. And as I alluded to towards the start of the presentation, some of these learnings in terms of dynamic biomarkers we're starting to transpose from the advanced setting. So the role and rationale of deferred cytoreductive nephrectomies is still pending post-combination treatment, but does afford us this window of opportunity to characterize these dynamic changes. And there are many in the global community, alongside some of the work that we're doing, which are leveraging more nuanced and refined technologies to provide deep immune phenotyping, characterizing gene expression at a single cell level with matched interrogation of the TCR and BCR repertoires, as well as doing deep dive immune phenotyping of multiple immune cell subsets, understanding not only the value from quantification of these cell subsets, but interactions within the TME. And we're starting to see consistent results from these efforts globally. Again, this notion of these mature TLSs in post-treatment tissue material, the broad and robust clonal expansion of TCRs associated with durable responses to combination immune checkpoint inhibition. And also, as we alluded to earlier, the importance of phenotype of these immune cell subsets and the emergence of both memory T and B cells. And importantly, these memory cell subsets, which are antigen-specific but persist in the absence of the antigen, are long-lived and may provide ongoing immune surveillance underpinning durable responses. So we're starting to build a stronger biological rationale for consideration of neoadjuvant immune checkpoint inhibition or therapy more broadly. And again, this makes sense. So the in situ primary tumor provides a greater neoantigen burden, which likely results in more robust T-cell responses. And we've seen this peripherally in the context of melanoma and in the context of advanced disease intratumorally for clear cell renal cell carcinoma, as well as the earlier emergence of memory B and T-cell populations, which may underpin more durable responses. And how does this translate clinically? Well, we know that those with highest risk localized disease may be underserved by adjuvant PD-1 therapy options, in which if we look across the phase 3 adjuvant studies, we know that there is a subset of patients who screen failed as a result of early emergence of metastatic disease, post-definitive surgery, but prior to commencement of adjuvant therapy. And this may be a subgroup, the highest risk subgroup, who may be better served by upfront systemic therapy options in a neoadjuvant paradigm, with the overarching aim of treating early micrometastatic disease. As discussed, we've seen these signals already in other immunogenic tumor types, but must acknowledge that the biology of these do vary, but also at a point where we can robustly define what pathological response is in the context of neoadjuvant therapy designs, the scope to develop and build adaptive therapy studies, and then in practice, de-escalation of adjuvant therapy in the context of response, or cross-modality treatment in the context of non-response. And really, these studies present a unique opportunity to redefine and validate the biomarker landscape here. These longitudinal window of opportunity studies characterize dynamic changes intratumorally and peripherally that will support patient decision-making not only in the perioperative treatment space, but the legacy of this may be applicable across the treatment paradigm. Thank you very much.
Yeah, thank you very much, Said. When we planned this session, we actually thought it might be very good to look at other tumor types, and the role model for neoadjuvant therapy is melanoma. And I think there's a lot we can learn from them, and therefore I'm very happy that we found Ben Shum available to give the presentation on neoadjuvant immune checkpoint inhibitors, lessons learned from melanoma. Please, Ben.
Okay, thanks very much for the organizing committee for the kind invitation. So I'm a medical oncologist with an interest in melanoma, although I've also been looking after kidney cancer till quite recently. But within the melanoma field, we've been quite lucky to have 2 positive neoadjuvant trials in recent years with 2 quite different trial designs. So I hope to discuss these with you in terms of what paved the ways to these studies and share some insights that could potentially be applied to kidney cancer. So in the last couple of decades, we've made incremental improvements in the treatment of stage 3 melanoma, with adjuvant PD-1 therapy being a standard of care for possibly the last decade. However, in the last 2 to 3 years, we've had 2 randomized neoadjuvant trials. So firstly, the SWOG S1801 trial with perioperative PD-1, and the NADINA trial with the neoadjuvant ipi/nivo, followed by pathological response-directed adjuvant therapy. And now both trials have reached the endpoint of superior event-free survival, which is defined as progression before surgery or recurrence after surgery or death. So going through each of these in turn very briefly. So firstly, the SWOG S1801 trial was a large phase 2 randomized trial across 90 sites in the US with a pragmatic trial design. The neoadjuvant arm was quite simple, of 3 cycles of pembrolizumab over 9 weeks, followed by surgery, and then 15 cycles of adjuvant pembrolizumab to complete the year. And then the control arm was the standard of care adjuvant pembrolizumab. The trial successfully demonstrated a superior event-free survival, but perhaps more interestingly and reassuringly, the treatment-related grade 3/4 adverse effects were similar between perioperative versus the adjuvant arms at 12% and 14% respectively. On the other hand, NADINA was a phase 3 trial conducted mainly across 27 academic sites. The neoadjuvant arm consisted of low-dose ipi 80 milligrams and nivolumab 240 milligrams for 2 doses across 6 weeks, followed by surgery. Now, pathological assessment was the linchpin here and really dictated the adjuvant approach. So if major pathological response was achieved, which was predefined by the International Neoadjuvant Melanoma Consortium, and which is defined by less than 10% viable residual tumor, then the patients did not have any further therapy. And so 2 doses ipi/nivo was all they needed. And if MPR was not achieved, they would continue to adjuvant PD-1 for the rest of the year, or switch to adjuvant targeted therapy with BRAF/MEK inhibition if they carried a BRAF mutation. And the adjuvant arm also consisted simply of PD-1 for a year. So of course, this also reached its primary event-free survival endpoint with a hazard ratio of 0.32. But remarkably, 61% of patients achieved major pathological response and thus had only 2 doses of ipi/nivo. And those who had a major pathological response also had a superior 2 years relapse-free survival of over 90%, shown in the green on the left. And perhaps predictably, this regimen was associated with a higher treatment-related grade 3/4 toxicity of 30%, which is higher than the 12% seen in the SWOG trial. Critically, the pathological response definition that is central to NADINA was established by the International Neoadjuvant Melanoma Consortium, or the INMC. The INMC was an international multidisciplinary group from 18 academic centers consisting of medical oncology, surgical oncology, pathology, translational research, imaging, and statistics. And their purpose was to provide consensus recommendations and best practices so that there would be an aligned approach to accelerate clinical and translational research within neoadjuvant therapy. And to this end, they organized working groups to address clinical trial development, pathological evaluation, surgical principles, and biomarker evaluation. And one of the first things they did back in 2018 was establish this statement paper here, which standardized pathological assessment in the neoadjuvant treatment of melanoma, dividing the continuum of pathological response into 4 categories. The key metric here was the percentage residual viable tumor, and pathological complete response, or PCR, was proposed as a surrogate endpoint. And this is based on the premise that complete eradication of disease in the local site will correlate with the eradication of any distant micrometastatic disease. And this correlation between PCR and RFS outcomes had been previously confirmed in multiple other cancer types, including breast cancer and upper GI cancers. But they also saw from pilot neoadjuvant melanoma studies that those with less than 10% residual viable tumor, named as near PCR, also had similar outcomes to PCR, and thus combined these 2 categories into major pathological response. Pathological partial response was empirically defined as 50% of less of the tumor bed occupied by tumor cells, and pathological non-response is more than 50%. But beyond pathology, the group also published the consensus document with an aim to standardize trial approaches, particularly focusing on 3 things. So firstly, they tried to identify or propose the optimal patient population, which is informed by subgroup analysis of established adjuvant trials. They also determined and recommended the optimal treatment duration of neoadjuvant therapy, balancing the risk of progression to unresectability and toxicity with efficacy. Secondly, they agreed on trial endpoints, so including safety, radiological response, pathological response, survival, and exploratory endpoints. And thirdly and finally, they focused on translational research and biomarker development with an emphasis on longitudinal profiling, understanding response and resistance, leveraging from what is previously known in the advanced setting, and also leveraging neoadjuvant trials as a platform for rapid drug development and biomarker discovery. So this allowed these trials to be comparable and later permit the INMC consortium to perform pooled analyses as early as 2021 to assess efficacy and toxicity. And this ultimately established major pathological response as a surrogate endpoint for RFS, and shown on the right here, that those with a PCR or near PCR had a very high RFS of almost 90% at the 3-year mark. And these pooled analyses that were achieved very early, then later would have helped inform the NADINA strategy. The INMC also pooled safety data, because one concern about neoadjuvant therapy may be that treatment toxicity or disease progression while on neoadjuvant therapy may lead to the omission of surgery. However, here, updated analysis from the INMC group from 800 patients has shown that omission due to ICI toxicity only occurs in 0.5% of patients, of course within melanoma. But if we return and compare now the SWOG trial with the NADINA trial, perhaps what we see here is a trade-off between efficacy and toxicity. And perhaps unsurprisingly, neoadjuvant ipi-nivo may be more efficacious, but is also more toxic. And so biomarkers are again needed to help stratify and personalize between these treatment strategies. I think my other observation here is that the SWOG trial has quite a pragmatic trial design that can be easily implemented around the world, with a similar toxicity profile to the adjuvant trial, to the adjuvant regimen, but maybe less efficacious than ipi-nivo. But on the other hand, NADINA is a personalized trial design and arms the patient and the clinician with prognostic information. However, it also relies heavily on pathological assessment, which could potentially be a barrier to wide uptake, especially in non-academic centers. And so, in summary, within the melanoma, neoadjuvant ICIs have a superior EFS to adjuvant PD-1 alone, and really represents the new standard of care. A standardized approach to pathological response assessment and the establishment of major pathological response as a surrogate of RFS was central to treatment personalization strategy in the NADINA trial. And perhaps some observations of neoadjuvant ICIs that might be extrapolated to other cancers, such as kidney cancer, may be that perioperative PD-1 had a similar toxicity profile to adjuvant-only PD-1, and that only a small percentage of patients did not proceed to surgery due to toxicity or progression. Neoadjuvant ipi-nivo appears to be more efficacious than perioperative PD-1 within the limits of cross-trial comparison, but with a higher toxicity trade-off. But more broadly, what I think the INMC approach has demonstrated is that the alignment of patient selection, clinical trial design and endpoints, especially pathological response, can permit closer comparison between trials and generate early insights via pooled analyses. Biomarkers are needed to personalize treatment, and there is real value in embedding translational research protocols in neoadjuvant trials and such that any candidate biomarkers can be evaluated prospectively and accelerating their implementation. And finally, early harmonization and collaboration can accelerate clinical trial and translational research. So thank you for your attention.
Thank you very much, Ben. So next we've got Guillermo de Velasco, who's going to talk about the key topic of how to select people best for perioperative treatment.
So hello, everyone. So first of all, thank you so much for the invitation. It's a real pleasure. Really nice venue. I'm on many friends. And I will be talking today about optimizing patient selections for perioperative RCC therapy. So the learning objectives for this talk will be understand factors relevant for selecting RCC patients for perioperative therapy and recognize the current limitations and challenges in predicting benefit from neoadjuvant or adjuvant strategies in RCC. So why is optimal patient selection critical? So that's the main thing. Is like we need to think that our goal is to maximize benefit and minimize toxicity, because many of our patients will be already cured just with the surgery. So the main point will be how can we select better our patients that they really need neo or adjuvant treatment. So if we think about the list of things that could be an advantage for either neoadjuvant or adjuvant treatment, there will be a bunch of lists quite similar to different, like any other solid tumors. But I just want to think about a couple of things. Like when we are doing neoadjuvant, this neoadjuvant treatment may help to assess in vivo response to therapy. And when we are talking about adjuvant, we have already one trial that has been proven to be positive for DFS and OS. But also there are some disadvantages. One of them is the most important one, in my opinion, for neoadjuvant, is like we have a lack of validated biomarkers for response. And when we are talking about adjuvant treatment, the main disadvantage is the risk of overtreatment due to the current risk stratifications limitations. So why patient selection matters? This is the theory. So when we talk about perioperative treatment, we know that only a subset of patients derive significant benefit. So what we will have is a lot of toxicity, cost, and surgical delays. So that's why it's so important, the personalized medicine, and try to select better patients. So that's the theory. And when we saw what happens, for example, in all trials with tyrosine kinase inhibitor, ASSURE, PROTECT, ATLAS, SOURCE, all those trials were negative, did not improve DFS, and we had a lot of cost in terms of toxicity. But now we have a shift to the immunotherapy. So why patient selection matters? This is the practice. So now we have the adjuvant pembro is the new standard of care for selected high-risk RCC patients, and we have an impact in overall survival. That's really amazing data. We have good data and nice to use in adjuvant setting. However, we have to acknowledge also that there are other adjuvant trials, Emotion, Checkmate 914, Prosper. They fail to show improvement in disease-free survival. So we need to be very careful about how can we select patients to use in our clinical practice. And I just getting this figure from Barata that presenting data on the discussion in last year. And if you see what's happening with the adjuvant pembro, we know that even you are using adjuvant pembro, there will be a lot of patients where you are over-treating those patients, and you'll have half of the patients don't really need adjuvant treatment because they have already been cured. That's why it's so important. Try to select better patients for perioperative treatment. So what are the most relevant clinical pathological criteria? Do we have any data really that we can select? Is like tumor stage? Is it primary tumor characteristic? Is patient performance status? We don't really know. How can we select those patients? And even when we are looking like different subclassifications, we see that in general, all of them get benefit with the adjuvant treatment. So we don't have data like clinical or pathological factors that will help us to select better our patients in the clinical practice. We don't know, and we don't have this data. And how is the high-risk populations? We saw what happened in the KEYNOTE-564. group by group, all of them got a benefit with a hazard ratio of 0.65 in the high-risk population, 0.77 in the very high-risk population, and 0.28 in the M1 and ED. So obviously, the highest risk, it seems that you will have better hazard ratio, but at the end of the day, we cannot select based on the TNM or these classifications to try to improve our data. What about molecular biomarkers? Can help better stratify patients eligible for neoadjuvant or adjuvant therapy? So what do we know so far? So we can use only for clear cell, because we don't have data in non-clear cell. What about biomarkers like PD-L1 expressions? We know that they fail, genomic signatures, KIM1, molecular alterations. So we've gotten a lot of information from the metastatic setting, but the reality is that although we are seeing very nice data, like for example, the KIM1 data that is really defining different subgroups, we don't have any single biomarker today that we can use in our clinical practice to try to select better patients for perioperative RCC. So at the end of the day, we need to do a risk-benefit assessment. And we need to be very careful when we are doing patient selection about recurrence risk and treatment-related toxicity. And one of the most important questions these days is that, can we predict response to immunotherapy in the adjuvant setting? Because one of the things is like, we don't know when we are giving adjuvant treatments whether those patients are really getting benefit from that immunotherapy. That will be totally different if we are using in the neoadjuvant space and we are seeing some response. And obviously, we need to think about moderating surgical risks. So I just want to put two different clinical cases scenarios. Think about the case A. This is the perfect case, effective and well-tolerated treatment. You have a patient with clear cell RCC, PT3 and 0. The patient gets adjuvant IO, no relapse. That's perfect. We don't know, although in this case, whether you are getting a benefit or not, but at least you are happy because the patient completed the treatment and no relapse. But now think in the different scenario. Second case, so you have the same patient, but this patient had severe toxicity, and this patient had a relapse. So now we have the total opposite situations, toxicity and disease recurrence. And the tricky thing is like when we are in our clinical practice, we don't know what's going to happen with our patient up front. So we are seeing those patients in our clinical practice, and we don't have a way to select the patients that will be in the case A or in the case B. Something very important about patient selections, the number needed to treat. And that, I think this is something that we need to keep in mind when we are doing perioperative treatment for our patients, because many of them will be cured. So if you look at the disease-free survival, this is an estimation from the KEYNOTE-564, you need approximately 11 patients to prevent one disease-free survival. When you are thinking about overall survival, you need to think about 19 patients to an absolute benefit of 5% and to prevent a death at 48 months. And when you're thinking about adverse events, grade 3, 4 adverse events will be about 18% of the patients. Okay, that's something that it's okay and it sounds reasonable. But now think about estimated annual candidates in Europe. This is an estimation. It may be wrong, but it's just to get an idea. New RCC cases in Europe, 136,000 patients. Eligible for nephrectomy followed for adjuvant, think about 40,000 patients. Clear cell, 34,000. Now think about what's going to happen with the NNT. So the impact of adjuvant pembro for that population will be that you will have a benefit in more than 1,000 patients, 1,600 patients. Overall survival benefit for 1,000 patients, but grade 3, 4 toxicity, it's about 4,000 patients with grade 3, 4 toxicities with pembro, and potentially over-treated patients, 18,000 patients. That's why it's so important to think about treatment selections. And obviously, this is an estimation. I may be completely wrong, but I just think about not just the data itself, it's like putting those numbers together year after year without doing patient selection. So future directions, how to integrate predictive biomarkers moving forward to truly personalized perioperative therapy. Definitely, there is so many factors to do treatment selections that we need to put together, and there is like a very important initiative about consortium. In melanoma, I think we need to move forward in kidney as well to try to put all these things together and try to do better our personalized treatment for RCC. So the take-home message is patient selection is critical to maximize benefits. So we have a nice treatment, but we need to maximize benefit and minimize harm in perioperative RCC therapy, and clinical factors, including stage, performance status, remain fundamental in decision making. So if the path isn't clear, I think we need to refine our criteria. Thank you very much.
Thank you, Axel, and thank you to the organizing committee and the track chairs for giving me the opportunity to present about challenges and opportunities in neoadjuvant and perioperative space. So learning objectives for these presentations are to introduce you to the International Neoadjuvant Kidney Cancer Consortium, its objectives, and also to kind of invite you to participate in this consortium. So here you see the results of a large retrospective cohort study from Dr. Libovic on your left-hand side, showing the results, long-term cancer-specific survival of patients that underwent a nephrectomy at the Mayo Clinic in the United States, showing that approximately 40 to 60% of the patients ultimately dies of kidney cancer. And on the right-hand side, you can see the results from the Keynote 564, the adjuvant study, showing at the 4-year landmark approximately 56.6% of the patients being without a recurrence. So really confirming that 40 to 60% of the patients with high-risk localized clear cell RCC ultimately die from kidney cancer. So one way we believe to address this problem is to develop highly active neoadjuvant or adjuvant systemic therapies. And the principal aims are to really increase the curation rates among these patients, to eliminate microscopic disease, and I think for many patients also secondary objectives to reduce tumor burden to enable surgical resection, particularly important, for example, for patients with tumor thrombi, and to delay disease relapse. But the ultimate aim is first of all to increase the curation rates. And to really get a view on the important research questions in this field, Axel and Grant have performed a Delphi consensus study last year. So they compiled a list of 35 key statements that were sent to important investigators in the field prior to meetings in Boston and in Amsterdam last fall, to really see on which statements are a consensus currently and where no consensus is present, to really identify the key research questions. And I think the most important outcome is that the teams in which no consensus was identified were assessment of response following neoadjuvant therapy. So there's, of course, overall survival, but are there any surrogate endpoints that could be of value? The optimal selection of the drugs, so which drugs to select for neoadjuvant therapy trials, and how to proceed with adjuvant treatment after neoadjuvant treatment. So to really put this in a different format, the key research questions that we are currently working on: what is the optimal drug or drug combination? What is the optimal duration of systemic therapy prior to surgery? Do all patients need both neoadjuvant as well as adjuvant therapy? And what is the optimal method for response assessment and therefore also the best study endpoint? So to really get a feeling of what's already known, James Blackmer and James Jones, two colleagues of mine from the United Kingdom, have performed a systemic review, and they identified 119 studies focusing on perioperative systemic therapy. And I think an important outcome is that the large majority of the studies were investigating either cytokine or single-agent TKI therapies. But of course, the more recent developments are the combinations, and those are a small part of all the studies that were performed. The large majority of the studies were investigating clear cell RCC, but many studies also included multiple histologies. But I think the most important outcome of this systemic review was that among the 42 studies that we identified, the prospective studies, the large majority, 37, were actually single-arm phase 2 studies that are, of course, not practice-changing, really calling for an effort to collectively organize phase 3 clinical trials. So this is then the studies that we are currently conducting at the NKI. So these 2 studies are part of an institutional-wide effort to develop neoadjuvant systemic therapies, for example, for breast, colorectal, bladder, head and neck cancers, as well as melanoma. But these 2 studies are aiming to at least get a feeling with the activity of 2 highly active regimens for kidney cancer particularly. In this case, axitinib avelumab in the NEO-AVEX study, a study that was conducted a couple of years ago and from which we now have long-term follow-up. And those results will be presented at ASCO this year. And the second study, the NESCIO study, in which we randomized patients to nivolumab, ipilimumab, and nivolumab relatlimab. Both studies included 40 and 42 patients and finished the accrual now. And we hope to learn at least something about the activity of these drug combinations. And of course, an important question in the field now is what's the role of HIF-2 alpha inhibitors, an important new drug in the field. Do we need to combine HIF-2 alpha inhibitors with these regimens, or what should be their place? So a number of studies is being launched now with these HIF-2 alpha inhibitors. So one important outcome from the last fall consensus meeting here in Amsterdam was that all the participants believe that there's a need, similar to the roadmap that was just shown by Ben in melanoma, to have a standardized approach for pathological response assessments in kidney cancer. So therefore we followed the guidelines of the International Melanoma Consortium, but really adapted that to approach particularly for kidney cancer. So we hope that this pathological response assessment protocol will be used in prospective clinical trials to really get a grip of what's the pathological response rate after all these neoadjuvant therapies, and to really see whether this could serve as a potential surrogate endpoint for overall survival in the clinical trials, because this could, of course, speed up the development of neoadjuvant therapies, we believe. So then to get back to the research questions, so what's the optimal drug or drug combination? Well, of course, I think one of the things that we learned from metastatic kidney cancer is that most likely we will move into drug combinations, but the near future will show us more about that. What's the optimal duration of systemic therapy? For example, in the NEO-AVEX, we treated patients for 3 months with neoadjuvant therapy, while in the NESCIO, we treated patients for 6 weeks. So I think that's still a little bit an open discussion. We know from metastatic cancers that many kidney cancers sometimes may need a little bit longer systemic therapy, but that's something that we will learn on the way, I guess. Do all patients need neoadjuvant and adjuvant therapy? I think the answer is most likely no, but it's again a research question. What to do when you have a complete eradication of your primary tumor after neoadjuvant therapy? Is there a rationale to continue with adjuvant therapy versus if there's no response at all, not even an immune cell infiltrate, do you then continue with 1 year long adjuvant pembrolizumab? I think that's also questionable. And then what's the optimal method for response assessments? I think overall survival will be the ultimate endpoint to really show that we are increasing the curation rates with neoadjuvant therapies. But hopefully we will also get away with some surrogate endpoints for the near future. So then the aims of the International Neoadjuvant Kidney Cancer Consortium. First of all, to harmonize the study designs. So we hope we will be able to collaborate and collectively organize large institutional studies We are currently developing a master study protocol available for all investigators in the field to really harmonize studies currently being conducted. With the new protocol for pathological response assessment, we hope we will be able to harmonize study endpoints, and we of course will also keep you updated through regular meetings at international conferences. So take-home messages. The International Neoadjuvant Kidney Cancer Consortium is an international platform for perioperative research into localized high-risk RCC, and we welcome you all to participate and to collectively move the field forward. Thank you.
Thank you, Kern. Microphone's working? Is this one working? Thank you very much, Kern. So we have plenty of time for questions, so please come to the microphones and interact with the session. So we've got Stefan Odard coming. Thank you.
Yes, thank you. It's working? No, it's not working. Yes, it's working. Thank you. Based on the melanoma, study, what would be for you the best, duration of treatment prior to surgery? Because it's very short duration of treatment, and you have no toxicity, or almost no toxicity. So, would you like to maybe to have a longer duration of treatment prior surgery in melanoma tumors?
Thanks for the question. I think the INMC consortium initially, of course, it's difficult to compare melanoma with kidney cancer, but the INMC consortium on their consensus paper agreed to 6 to 8 weeks of therapy. I think that's probably a good balance in terms of the PCR rates and the major pathological response rate that we see. I think 60% is quite a high major pathological response rate. I think the way forward may not necessarily be to increase the duration of these treatments, but maybe we're investigating newer combinations of IO, and for example, we're also doing neoadjuvant trials of LAG-3, neoadjuvant trials of TIGIT that have been reported. So I think maybe the way forward is not necessarily increasing the length of the duration, because the response may well be established early on, but more to investigate whether there are other IO combinations that may be more efficacious and maybe less toxic.
Thank you.
Ben, maybe I can just ask you a bit more about the INMC. So as you've seen, we're trying to develop something analogous to that in kidney cancer. And it looked like from your slides in melanoma, this was very influential in making progress. So firstly, how influential do you think it was? And secondly, how did it work in reality? What interactions with the community were there with INMC?
Yeah, so I think they had numerous meetings. I think that in their consensus paper, so they published that they had started meetings, up until before 2016, 2015, and they've had numerous meetings, maybe once every few months or so. So what was the first part of the question again?
Just, how influential you think it was. Would you have made the same progress without it?
Yeah, no, I think definitely it was very influential. The linchpin being the pathological response rate, and that sort of statement paper was really central to the NADINA trial. Secondly, I think, as I sort of alluded to in my talk, the pooled analysis, the consensus allowed also for pooled analysis. And I didn't show all of the, data, because I guess it's melanoma-specific data, but it really showed a lot of insights pooled, because there were many phase 2 trials that were around the world, but they pooled, for example, showing combination ICIs compared to single-agent PD-1. They also compared and demonstrated that neoadjuvant ICIs had a very different outcome to neoadjuvant targeted therapy, even if you had a PCR. So, in demonstrating that, even if you had a PCR to either therapy, you had very different outcomes, because ICIs, if you had a near PCR or PCR, you would have a 90% relapse-free survival. But if you had, but in BRAF/MEK inhibition, if you have a PCR in a neoadjuvant setting, your 2 or 3 year RFS is actually only about 60%. So it's very different, and it showed us a lot of insights early on and really informed, I think, the trial strategies.
Yeah. Ignacio?
Hi, Ignacio Duran from Santander, Spain. Well, wonderful session. Congrats to all of you. I have a couple of questions, one for Ben, one for Guillermo. So Ben, you were commenting on NADINA trial, and one of the cons was the 30% grade 3/4 toxicity. Can you expand a little bit more on that? What kind of toxicities? It's not the same thing if you have a grade 3/4, let's say hepatitis versus central nervous system or hormonal. What was the profile of toxicity mostly?
Yeah, so they were, in terms of the distribution of toxicity, it was quite similar to what you would expect from Ipi/Nivo in the advanced setting in terms of the distribution. So mostly cutaneous, endocrine, a bit of colitis, hepatitis, so all the common things. I think the other thing to note is that the neoadjuvant NADINA study with the dosing of the Ipi/Nivo was actually flipped compared to the metastatic stage. And that was, owing to work building on that from the APASA-NEO trial, which was a phase 2 dose-finding trial comparing 3 different regimens of Ipi/Nivo to look for what is the best combination of efficacy and toxicity.
And do you have numbers on chronic toxicities?
So I think the follow-up from the NADINA is up to about 2 years at the moment. So yeah, that's what we have.
Thank you. And my question to Guillermo is about, I completely agree. We're over-treating patients. We need to work on patient selection. Toxicity is an issue. We're actually presenting a poster about that here this year. But, how do we approach this? Are we being very picky? Because we use a lot of adjuvant treatments with other tumors where the benefit in survival is probably not greater than what we have with kidney cancer. Then, one example could be breast cancer, for instance. Or, in bladder cancer is 6 to 8%, 5-year overall survival benefit. So, what would be enough for you, and what do you do in your clinical practice? Yesterday, we discussed with Laurence the use of different nomograms, but, when you talk to the patient, going back to the shared decision-making, what would be sufficient to push your patient in favor of adjuvant?
What I was trying to be controversial about numbers, and that's the key point. But now we have one drug that has proven to impact in the overall survival. I think in general, at least in my clinical practice, it's enough to present or to offer to every single patient. But I think it's something that is not every single one should receive adjuvant pembro. I think that all patients that are eligible should be offered the treatment. And obviously, there will be always a balanced risk, and I think we need to explain, and that will be a shared decision between the physician and the patients. But I think it's a well-informed patient will be a good candidate if he agrees.
Yeah, thanks a lot. I think Niels.
Yes, hello. Thank you for the great talks. I'm Niels Fristrup from Aarhus in Denmark. I'd like to ask you, we haven't been around this topic. What about ctDNA? Looking into these numbers of patients you need to treat to save one person. We have new methods. We have methylation-based assays that looks better. What are your views on this?
Yeah, thanks, Niels. Maybe I can take this question. So I think probably the ctDNA space needs to be refined a little bit. So ctDNA in its most traditional form, tracking genomic variants, has struggled in kidney cancer, and that's largely because of low levels of tumor shedding, high sequencing depth, which drives a lot of artifact. It's exactly to your point, if we look a little bit more broadly beyond this, and you've mentioned methylation profiling here, the signals are definitely stronger. And I think beyond the DNA or cfDNA space, as I alluded to, we already know that there's value for KIM1 here, as well as these dynamic or longitudinal changes in PBMC profiling, these immune cell subsets, which early on treatment are very good at predicting response, resistance, and even the emergence of toxicity.
Great, thanks.
Thanks. Laurence?
Thank you, wonderful session. Thanks a lot. So my first question is for Ben. Thank you for sharing the melanoma experience. Are you aware of health economic analysis in NADINA to highlight the fact that these adaptive techniques would actually be worth of value as well?
Yeah, that's a really good question. I think, based on the fact that 60% of patients have a major pathological response and only need 2 doses of Ipi/Nivo, I think in itself would be quite clear that it would significantly reduce the financial toxicity compared to, for example, a year of adjuvant Pembro, of, whether it's 12 doses or 9 doses. So I think the math is there, but I'm sure that more formal financial calculations will be underway. But I think even just based on that headline alone, we can justify that. And of course, we need to take into account toxicity, but I think a lot of the cost does come from the drugs these days.
Thank you. And my second question is for the entire panel. Yesterday, we had a very interesting think tank. And thanks again, Grant, for pushing us in the neoadjuvant space. And one challenge we're facing is to increase the likelihood of benefit of the neoadjuvant approach is to better select the patient. So maybe I'll start with Zaid, but any panel member can answer. How can we select better the patients more likely to respond to neoadjuvant, like those higher risk that could benefit from the neoadjuvant strategy?
Thanks, Lawrence. It's like I'm back in my Viva again. So, yeah, great question. And I think this needs to be an integrated approach. We've talked about the struggles and difficulties of single biomarkers in isolation to reconcile diversity in response and resistance. So I think relative to clinico-pathological features, refining that towards and skewing it towards higher risk. We know that there are challenges associated with grade in isolation. This is heterogeneously expressed in tumors. So those T2 grade 4s will be challenging in some aspects in the absence of sarcomatoid or rhabdoid dedifferentiation. And then I think really what we need here is to understand the mechanisms of these biomarkers longitudinally. So with these neoadjuvant studies, to bank samples, profile them in real time, to understand what these signals are that can add towards those clinical pathological features to better refine.
Yeah, I mean, I could answer to this. We've discussed it yesterday during the think tank as well. I think from the perspective of finding clinical parameters, we would probably have to go by CTNM, clinical TNM. But it became obvious that it would be very helpful to have another consensus meeting on, because at the fringes, I think there are some different ideas. We all agree about the large T3 tumors and those ones with venous invasion and then higher grades. But I think that TNM alone will not get us there, so we would probably need other factors. I would also have, very briefly, another question, because we haven't touched on that yet, for Said and then also Kuhn, is it emerges from melanoma that the current understanding is that we use the pathological response whether your neoadjuvant therapy was successful or not. Now this is, if you take, for example, the study we did with neo-AVAX, 3 months, 6 or 8 weeks, do you think there are any on-treatment markers that could give us an earlier indication whether the treatment will be successful? So for example, any burst in peripheral blood mononucleosides or?
Do you want me to go? Yeah, I can start off. Yeah, so I think it's exactly as you say, Axel. I think the peripheral signals are going to give you the early signals. So we've seen really nice work from Hayden Kissack's group from Emory, which has demonstrated exactly as you point out, this burst of a subset of CD8 T cells, HLA-DR, CD39, so this activated phenotype within the first 6 weeks of treatment, which is associated with durable response. I think tumor-related features will be difficult relative to access, but certainly PBMC profiling may give us an early readout here.
Yeah, so I think we know from our current studies that the activation of the immune system is a key aspect of the activity of these systemic treatment regimens. And indeed, circulating immune cells may have a role, but also ctDNA, all kinds of circulating biomarkers like KIM1. But I think we will have to find out on the way which biomarker is actually best.
Great. Question from the floor over here.
These microphones are not very good for very short people. So great session. I had a question specifically about pathological assessment. Obviously in the melanoma space, the assessment of pathology after the neoadjuvant treatment has been hugely important. In kidney cancer, of course, some of these masses are going to be considerably bigger than some of the melanomas might be. And I was wondering whether the consortium had thought about other approaches to the sort of the assessment of the tumor, maybe some of the cool imaging techniques we were discussing in the last session.
Yeah, so thanks for that. So Kuhn, Axel and myself have been involved in this paper, which has been led by key opinion leaders in the pathology world across Europe and the US. And so we've set out this sort of standard way of sectioning the specimen. But as you say, these are huge tumors in many cases. And so at the moment, that's only suitable for a research setting. Of course, digital pathology, automated analysis of that can hopefully lessen the burden. And I think that's absolutely got to be part of the research that comes out of that standardized approach. So thank you very much. And we've got a question over here from Martin.
Yeah, hi, Martin Voss, New York. Thanks for a great session. I have a question about neoadjuvant strategies and duration of neoadjuvant therapy prior to nephrectomy. So we've heard from Ben about melanoma and 2 doses of ipi/nivo, and we've all talked quite a bit about PROSPER and why the neoadjuvant nivolumab experience may have failed for under-treatment preoperatively. We ourselves are looking quite a bit at the experience in the metastatic setting and patients that we treat and ultimately take to cytoreductive nephrectomy after IO-based therapies. And the signal we have here, I was talking to Arya Kimi about it just now, seems to be that we need to treat quite a bit to get these deep responses in the primary tumor in metastatic setting. A lot of these patients are treated for 6 months, 9 months and onwards, and we see amazing responses in the tumors. So it makes me wonder, how long should we treat on a pure neoadjuvant non-metastatic trial? We commit to these study schemas and then we treat everyone for the same duration. And I wonder if some of these trials are going to fail because we don't give enough doses of neoadjuvant. And I wonder to the panel, are there any studies that you're aware of or trials that actually look into that specifically and that leave the option to treat some patients longer than others for comparison with the same regimen?
Thanks. Koen, do you want to take that with your experience?
Yeah, so I totally agree that this is an very important research question. I have to admit that I'm not aware of any studies that are really investigating this particular question. But I do think that we will learn from all the currently ongoing neoadjuvant studies, which use different durations. So for example, in NESCIO we used 6 weeks, while in NEO-AVEX we used 3 months. While the WIRE trial, for example, is really a window of opportunity with also a very short treatment with another highly active compound. So I think we will learn on the way. And it's also a little bit of a question whether we really need to extend to really achieve a pathological response, or whether only a short course of treatment and activation of the immune system with like very highly infiltrated tumors is also sufficient to achieve long-term benefit. So I think there's still lots of questions surrounding neoadjuvant therapy.
And I guess one of the most important questions for this is, are we ready to treat our patients that may be cured with surgery with 6 months of perioperative therapy? I don't know if we are ready to do that or not, because we don't have a real good biomarker to help us to do it. That would be my question.
So in the meantime, while we are all writing these trials, do you have a sweet spot in mind? What do you all do if you set up the next study? Like, we just started a new neoadjuvant trial, and we decided to treat the patients for 9 weeks up front before, and it seemed like a good idea based on some of the preclinical data we have as to when we see immune activation and some of the surgical safety data we have as to how long we can wait. So that for us was sort of this sweet spot. But how do you all think about that? If you were to write a new study now, how long would you treat a patient preoperatively?
Well, I think it's a difficult question, but when we did an analysis of what most studies that are currently ongoing use, it's 3 months. Now, that doesn't mean it's correct, but I think you have to keep the balance between, for example, if you find out that nothing has happened in the primary tumor, it's like keeping a patient on a waiting list for 90 days, so I think it's not so attractive. So you have to keep the balance, and I believe that it is somewhere in between 6 weeks and 3 months, and 9 weeks may be a good point to take forward. Yeah.
Thank you.
Unfortunately, we have to come to the end. So Niels, if your question is very short and quick, we would allow.
Yes, so Niels Fristad from Denmark. I'm PI on the Nordic Sun study. So in the metastatic setting, I can tell you that we're close to 100 patients, and our learnings about the sweet spot is probably around 6 months. So 3 months' time is a bit early. 6 months' time seems a very good time to go in. Yeah.
Thanks very much for your comment. Unfortunately, we have to close. I would also like to thank every one of the presenters. I think we had a very interesting discussion. Some information, housekeeping. Please join us in the Grand Spur Saal, that's Dutch, which means Grand Spur room, for a 20-minute break with the exhibitors. Sessions will resume at